We have issues that made the doctors to go on strike and then be dismissed. In this, our negotiation that we've had in this framework, all those issues have been resolved. Again, because it's always an issue of give and take, we have looked at the period and the budgeting and the goodwill of the county and also discussed with these doctors. It's always not about money only. It's always about the need to serve the people.
Welcome to Straight Talk, where we engage Kenya's brightest minds in the issues facing our nation. This episode, we are privileged to be joined by Dr. Davji Atella. He's the Secretary General and CEO of KMPDU. Thank you so much for joining us.
Thank you, everyone, for having me today.
Tell us, how did you find yourself in the position in which you are today?
I found myself as the Secretary General and the CEO of KMPDU through service. When I was done with my internship after my undergraduate, I was working in Nakuru County. And we have a union, KMPDU, which has been in existence since 1971, but was registered in 2010. And therefore, in 2013, 2014, when I was in Nakuru, we had issues, the recurrent problems that were occurring in the county, where the county will pay salaries late, almost 2 months late. The issues of promotions were not being done. The issues of welfare were neglected. And therefore, in all our forums of discussions, we could voice out with courage to force the county government to get their things done. And it is that process that the doctors in Nakuru County in 2015 asked me to represent them as their branch secretary, which then I was elected to represent the region, South Rift, which has about 60 counties. And later, I think in 2018, I was doing South Rift and also helping my colleagues in the North Rift region. It is out of the work of about 5 years, that is 2015 to 2021, where there was results and impact for each and every doctors in South Rift, that is Nakuru, Laikipia, Kajiado, Narok, Bomet and Kericho, and also in North Rift region, that made the doctors see the need to actually ask me to vie for the position of the Secretary General. And it is the drive of the work that you were doing that led me to be elected in 2021, April, as the Secretary General. In our union, we have what we call universal suffrage. You move across in all the 47 counties to ask each and every doctor to vote for you. So it means that we get mandate from the doctors voting to be represented. That's how I became a Secretary General now for almost 4 years. And again, the CEO aspect of this is because as a Secretary General in the Labor Relations Act, you are the executor of the decisions of the National Executive Council, the day-to-day running of the union. So it means you have to be on a full-time basis to make these things done. We represent the welfare of doctors across the country, in both the public sector, in the private sector, and those also working in the universities, to see to it that in the hospitals where they work, they're able to be facilitated, supported, and to see that patients actually are served as expected.
You have a background then in bachelor's in clinical pharmacy
Yeah.
and a master's then in medical law and ethics. How does this help in how you approach leadership at KMPDU?
In the KMPDU represent 3 cadres, that is the medical officers, the pharmacists, and the dentists. And in the day-to-day running of operations of the workers, in the engagement with the governors, in the engagement with the government, you cannot just do it out of ignorance. In fact, in many situations, it is out of not knowing that people are haphazardly suspended from work. That is out of not knowing that counties will delay your salaries, statutory deductions are not remitted, that collective bargainings are not implemented. So for you to actually be equipped to do the work that protects justice and ensures that the right of workers are protected, the right of workers, which doctors in this case are protected, we must be well equipped as a union. We must have this aspect of capacity building. So that is the essence why we need to have the matter of the law and ethics. And we have a number of our leaders that have also been trained or capacitated in this matter of industrial relations. This is to enable the leaders within this sector that whenever you go to engage on collective bargaining, you know what you're talking about. When you say that an employer has contravened the collective bargaining agreement, like we went on strike last year, we have to follow up those particular actions. When you are in court like today, where the matter of social authority is ongoing, and as those who won the case in last year are not part of their appeal, we have to be able to actually move the court to allow to enjoin the union. So all this requires us to be well educated, requires us to actually know the social aspect of life, know the critical aspect of it, and actually know how to relate to all the matters. So that's why we as a union do not really go the traditional movement of being on the streets only. We are also capacity built to ensure that in our advocacy process or in the pursuit to ensure justice, we go by the book.
Now, you have a very unique position in that you've served under two presidents, President Uhuru and President Ruto. And within that time, there's been a transition to universal health care. From your perspective as Secretary General of KMPDU, how has that transition been?
You know, universal health care conversation is not new. It is something that has been in the country for now, the last term of the last government rise to the gym for 10 years. And now this one. I think last year was the fourth, 2023, October, was the fourth time that universal healthcare was being launched. And we came to realize that
the fourth
time that it was being launched, because it has been launched, the piloting was done in 4 counties. And then after the piloting, then there was a rollout in 2022 that captured like every country. Then again in 2023, there's another relaunch. And in fact, this is now when the country was coming to have the social health authority.
So really, when seeing the actual implementation of what universal health care was envisioned to be currently.
Yeah, that's what we are seeing now. But as I say, the dream of universal health care started much earlier. Former government.
Yes.
And if you look at the tenets of it, it's a key that anybody will support. Any individual of a country will support the idea, ideology of universal health care, because it just means that any person in the country should be able to access healthcare devoid of their socioeconomic status. That is, if you wake up today and you are a Kenyan, you are sick, whatever ailment you have, you need to go to the hospital and get the care. But then for that to be achieved, it means that there has to be financial investments to ensure that there's healthcare. There needs to be investment on the human resource. There needs to be investment in the infrastructure that actually provide those services within the hospitals. There needs to be investment in the equipment. There needs to be investment in governance and leadership. So in case any of this is not done, and the biggest one, the investment in human resource, in case these ones are not done, then we end up having knee-jerk reactions. We end up trying and not reaching where we are. And that's why there's a big difference in last trial and the current trial. As much as we are seeing a bigger conversation on social health authority, where there's a plan to have everybody able to access healthcare without necessarily have to contribute because now they're above that part of the primary healthcare, which the government taxes actually contribute to. Then they have the part where people are contributing, and then the part of the chronic healthcare. But because the money is still not enough, that's why we still have, yes, people are getting the care. You go to hospital, and social health authority approves. We have a bigger population that has been approved for. But on the flip side, we have hospitals that have provided this care, but they've not been paid. They still owed the money. So
from what I'm hearing then, you've highlighted 5 key areas in which must go along with the implementation of universal health care. And from, again, what I'm hearing from you, there are teething problems, absolutely, but at least there is implementation of SHA, or universal health care as we know it. Yes, there is implementation, and we must give credit where it's due. Where we have come from, the social authority now is different from where it was in 2023 when we went to court and object so many of its articles. Because, for example, now at that time, the chronic health, like cancers, were about 300,000, but I see now it went to 550, and now it's being proposed to 800,000. These are improvements that are coming in because of a responsive cabinet secretary who then take the inputs of stakeholders to improve this. But I can say that social health authority is just one component
of universal health care in the sense that it ensures that people can access the care. But for it to work and be more effective, there has to be more funds to it, so that when people have accessed care, the authority does not struggle to pay the services that have been provided by both national government hospitals and the private hospitals, because Yvonne, healthcare cannot be free. For healthcare to be realized or to be attained in any hospital, somebody has to pay. When you go to a hospital that is privately owned, the drugs there in that hospitals, the equipment, there are reagents, and there is human resource that have to be paid. Have to be paid for one service that have been offered. So this has to be paid by either that person who is seeking the care as a patient or by the insurance. The same happens in the public facilities to the extent that if it is not paid, then you'll access the care, but the next person who will come after you will not access the care. That's why insurance is very key to help people actually access this particular care. And in the event that you don't have the insurance, then there is a lot of out-of-pocket expenditures. That's why people will go and buy land and sell their lands. They'll go to different mchangos. You'll sell all your property. And that's what will give us the national healthcare, the increased investment. The other component which is very key is the human resource. The human resource is what makes it possible in those hospitals that have been built in different counties, that when you go there, you access care. It is like if you have an hospital where there are no human resource, it's just like a school where there are no teachers. You can't expect people to learn. Or is an hotel. It's more like an hotel because there's no services you can get. So the reality is that there's need to have human resource in those particular hospitals. And that's where we have not really done well, because the health is devolved. That 47 counties then have to do the annual recruitment of healthcare workers. And what have they done in the last 10 years? Before devolution, up to 2023, there was annual recruitment of healthcare workers, including doctors. You graduate, you have your appointment letters to the hospitals, and the numbers were subsequently increasing. But after 2016, when the county governments said that they have reached the ceiling of the PFM Act, and they cannot, that's the Public Finance Act, and they cannot hire any more. It means that there's need in this hospital. There's a shortage of healthcare workers, a shortage of doctors, but they can't hire. And therefore, what then happens is that there may be a vision by government to have people access healthcare public facilities, but unless healthcare workers are employed there, it becomes difficult. That's why unions like MPDU have been mobilizing and advocating that we need to have a plan like that of teachers, where there's annual employment, annual budgeting, or that of the police and the military, where we have annual recruitment like that, those are currently ongoing.
We also hear issues of cartels within the UHC system, yes? And we've also seen ghost hospitals as well. So when you talk about medical institutions registering to be part of the UHC, there has been implementation or implications of corruption within the system. How do we tackle that?
You know, corruption has been part and parcel of society that we live in. It's a problem to the givers and the receivers of that particular bribe, whatever situation it is. But corruption in healthcare is a worse situation, because whenever anyone tries to do corruptions on the drugs, the livelihood of the people who depend on these drugs, all the patients, is at stake.
Or medical institutions that are registered that don't offer any services and don't exist. How do we tackle that?
Even the medical institutions that then are acting to defraud the medical insurance are in all the way immoral in its nature of action. Because you know that this money is pooled together with one aim to alleviate people from suffering, that they may get this particular care. So the moment there are any elements of frauding in an hospital where you say you're offering services that you don't offer, there's a problem. And that's why I'm trying to put it that any matters that relate to the health corruption should not be treated like any other corruption. Because you may do corruption anywhere else, maybe in schools or anywhere else, and people will still be alive. But when you do corruptions, whatever manner of it in health sector, be it in drugs, be it in the one we saw in KEMSA, be it the one that relates to stealing drugs, stealing medications, or finances that are meant for medical insurance, or whatever form of it, is in a way affect the access of care to the people. And that's why we must as a country, look for ways to eliminate it in all possible ways. So, like, for example, what was being brought by social authority, or what has been always a communication, that there was a big defrauding effect in NHIF, which was involving both the members of NHIF and the hospitals and the operators in it. The same way they brought social authority to actually eliminate that particular aspect of corruption that was existing. The plan that the government has had, that we have seen them communicating, was that if there was suspicion in any hospital, then they will stop the payments. In one way, that is good. But on the other way, there has to be timelines to investigate whether whatever alleged corruptions is real, or just a misunderstanding between the authority and the hospitals. Because otherwise, if there's some hospitals that may suffer when in essence they're actually offering a great procedure. But when any hospitals or any individual is found culpable with criminality of defrauding social authority or defrauding in any other way any organizations, the law needs to be very severe on these particular persons, because that is what has made it possible in developed countries to actually eliminate corruption. Because when you are found that you're actually trying to mess up with the system of healthcare to benefit you, while the rest of the patients of the community are suffering, you need to be dealt with.
Is there any justification then for medical institutions to keep patients against their will when they fail to honor their medical bills?
It's just a matter of ethic, and it's a matter that has been canvassed in very many forums. I think the courts have really pronounced themselves on this matter in several instances. For example, there's a time that a patient was detained at Nairobi Women's, and the court made it very clear that the freedom of association, freedom of movement should not be detained because of the costs or because of inability to pay the cost. And I think in that judgment, the court, Nairobi Hospital having contravened this particular act, were told that they were told to pay cost. And from that cost, it covered the medical cost and paid this particular patient. We have seen other judgments in this regard also. Even as a union, we've gone to court against Nairobi Hospital when one of the senior professor doctors was detained in the hospital. Why? Because during the COVID, he was a psychiatrist. He was sick and he passed on, and the bills could not be paid. And the court ordered for the corpse to be released for burial. So, ethically, it's not right to detain a patient or anybody.
So, do the hospitals have a justification in doing that?
And
As Secretary General,
I'm going
what
there
do you
that
think?
ethically it is not right. It is not justifiable to actually detain a patient or the body in any of the hospitals in the country. But as I have explained to you, that there are operation costs that are there for hospitals, that are there for both public and private hospitals. And therefore, when they offer services and you cannot pay and they have no means to get to pay, to have you pay, it means that we are denying services for the next level of patients. And that's why there is need urgently for this aspect of indigence to work, so that those who can't pay are actually paid for. There's need for social health authority, these components of chronic care to work, so that the public are able to get the services. There's need for emergency and critical care, because this was not there before. And you realize that the Constitution provides that every Kenyan has a right to access healthcare and even the emergency healthcare. That's Article 43.
That then leads back to the conversation then again about funding into
so there's
universal health care.
There's need to be funding, and also there's need to be a provision that allows these hospitals, the private public, that when you go there and you get this particular care and you're not able to pay, there's an insurance that pays it. There needs to be provision that when you have emergency care and you are like unknown from anywhere, you get services, but then the hospital also get compensated. Because yes, the ethic and morality of being detained is wrong, but we have to get a mechanism that hospitals are also compensated for the services that they've offered.
There are some people who say, well, yes, I had SHA and I registered and I've been paying and I've been deducted, and yet somehow my bills aren't covered. How do you explain that to them?
You know, there are several matrices in social health authority that have been explained in very many forums. One thing that I know for sure, the difference in NHIF now and as it was social health authority, that in social health authority, SHA, immediately you register, you have access to primary health care, that is level 1, 2, 3, that you will go to any private or public and get the care.
Okay.
And that's why majority of the populations have gotten the care in those hospitals, and some of the private hospitals are still some of the hospitals are still waiting to be paid. The other component of it is that in now the shift, social health insurance fund, which is contributory, then there's now packages of access to package and benefit that you go to the hospitals, and it depends on which hospital you've gone to also. Because if you go to like Nairobi Hospital for let's say as a cesarean section, and you go to Nakuru level 5 or to Kenya National Hospital, the package that's been put there is like 30,000. So you realize that if you are in Nakuru level 5, that will cover.
There's a price discrepancy between
there.
the two institutions.
When you go to Nairobi Hospital,
Yes.
they will decide to charge you 100,000.
Yes.
So the Act provides what you call co-payment.
Or for 30,000 shillings.
Yeah, so once you go to that hospital, like Nairobi Hospital, they'll pay that.
Yes.
But it's now you to top up that,
Okay.
the difference. That's why if it were that the public hospitals are working effectively as is envisioned, I don't think there's anybody who will be able to pay any extra in public facilities. And therefore, that comes to the fact that for a real functional universal healthcare in any setting that we have seen, it has robust functional public health facilities, because these are geared toward public good. They're not geared so much into profit margins. But when you look into level 4, level 6, level 7 status private facilities, then the costs tend to be much higher. And that's where that aspect of co-payment comes in.
So from your perspective then, CEO, Secretary General of KMPDU, you believe in universal healthcare, in SHA, in SHIF, and the direction in which it's going. What recommendations or what would you like to see going forward?
We as a union, we won't say that we believe in universal healthcare, and we want it to work into the greater extent that every Kenyan is able to access healthcare without really need to worry about finances. We know that the Social Health Authority has had its challenges, which we as a union has come out in in different situations to discuss them. But as now we can say that it also has its gains and benefits that can be seen based on the leadership that has there in the ministry that now is allowing the inputs and the conversations to actually input these changes.
What gaps would you like to see filled?
For example, it is very proper that this matter of chronic health care, I know they've increased it now to 800,000, but it is still very crucial that when somebody has oncology or has cancers and is getting their oncology care, they need to be covered fully. Beyond the 800,000, because I know that some of the costs go beyond that. That's one thing that is very critical. I also look into it that some of the packages that they have, and I am happy that there's Professor Jaoko, who is the chairman of the benefit packages, that there's need to ensure that these packages are increased to the point that there's almost elimination of the co-payments in most of the facilities. But the reality is that cannot work if majority of the Kenyans are not contributing. Because as I told you, healthcare is not free. But when we have 30 million or 27 million registered, and we only have those working, those who are in wages or salaries,
5 million
5 million
Kenyans.
paying,
Yes.
it becomes almost an impossibility
5 to 6
for these
million.
5 million to carry the 30 million on the back. So as a responsible citizens, we also have to look for mechanisms to contribute, because when we come out to just criticize this particular social authority and saying it is not paying after we got the services to the providers and we are not paying into it, there's a problem. And therefore it cannot work. So, and we will be contributing for it not to work. So there's also responsibility for us or for Kenyans to actually ensure that when we want this pooling of funds to work, then we must be able to contribute. If you have registered 26 million, then we need to contribute, because then that makes it easy for unions. It makes it easy for civil society, for different bodies to lobby this package so that it can actually benefit everybody. That is for the Social Health Insurance Fund. But on the other side, the primary health care, which is also free, there's also, which is free, there's need to increase the package for the money for it, so that once they give the services in these facilities, the payment is done promptly. So I believe those are some of the things that need to be done by us and by the the government, and even by the providers, so that it become a joint actions to how to make it work. But when we have this aspect of only pointing fingers, then we become part of the problem. Why? Because we have here, as we speak, we have the Social Health Authority as the only insurance. So we must look into it. How do we make the government or the authority to increase the packages so that people are covered?
So there's a responsibility on us
Yes.
to own
There's
universal health coverage
Yes.
and embrace it. Otherwise, it doesn't work.
It doesn't work. And when it doesn't work, it's a bigger danger. Because when it doesn't work, it means that the doctors can't work. Because when you have patients who cannot pay, then there's no provision of healthcare that can take place. Yes, the politicians, the members of parliament, members of the Senate, they have a bullet in their hands. They have the biggest stake in this matter because they make the law. And also they have the provisions of the budget. It's therefore beckoned upon them as the representative of the people to ensure that there's enough funds in this particular body and there's enough benefit package that Kenyans can actually access the care. Yeah.
Okay. You've had, during your term, lots of strikes happen, interns striking, and a lot of uncertainty within the healthcare industry. What is the motivation behind this?
You know, an injustice is something that can never be tolerated. And agreements that are done by employers with employers and employees must always be respected. But we are in a country for a long time where you will have agreements, you will have collective bargaining agreements, you will have return to work formulas, you will have all the promises that remain very nice and rosy, but then they cannot be implemented. So our responsibility as a union is to see to it that every benefit that we have been documented is implemented. Like, for example, we had a strike last year that went for 2 months. It was on 2 issues. We have a collective bargaining agreement that had gone for 7 years, where our salary increment, which was then given 2016, has not been paid. So to us, it was like we are seeing many taxes coming up, reducing our payroll in our take-home. But then we are seeing that we are owed money that has not been paid. So we came out strongly demanding for that implementation. I am happy that in December, we got 50% of those arrears, and in September this year, we also got paid. We only have a balance of about 1.5 years to go, and we are having engagement on that. The other thing was on interns. We have agreed on intern wages, which was slightly higher than what they were earning in 2009.
Yes, 206,000.
206,000.
Yes.
Which was higher than what they were earning in 2009, which was 2009 they were earning about 150,000. Then here comes government with the former minister stating that interns do not deserve to earn such wages. And without consultation, reducing the wages by over 70%. And that calls for war. It doesn't call for any reasoning or any discussions, because even the action of injustice that is being perpetrated did not have any consultation. And that's why we were on that particular strike. And most of the time, we go on this strike to ensure that we protect what we have gained, and we're able to be supported to offer the best care to the patients. Because when your salary is delayed, when you are not promoted, when you are overworked without employment of more doctors, when you can't go on leave, when your salaries cannot be paid, when statutory deductions like your loans, your pensions are not guaranteed, then you are worse than a slave in any hospital. It means you are a patient, because you'll be at work and you're mentally worried whether your house will be locked by the landlord. You'll be at work, but maybe you can't even pay fee for your children. You'll be at work and you have to borrow your cousins and your relatives to actually bring food on the table. So it means you are actually a patient. That's why we are united as doctors, that to say, whatever deal that you've worked for, whatever agreements that we have had, ought to be complied with. And if not, then we will always action the Article 41 of the Constitutions that give us the right to strike, the right to protest, and the right to bargain, so that these things are honored.
It's so interesting. As a doctor, a medical professional, you would imagine that your voice would really be within the medical field, and yet here you find yourself being a politician, tackling and butting heads with politicians, fighting for the rights of those who you represent. How do you balance that with your profession?
You know, Politics is an issue of interest. And most of the times when we have political conversations, it's a matter of sharing the limited, so said, economic thing, the economy, or the existence of interest. So when we, but to be clear, we are not politicians. I am not a politician, neither am I a student of politics. But the reality is that the policies, the conversations, and the political class tend to take everything that otherwise the workers will have. You realize that the owners of these big industries, the hospitals, even the government will ensure that they take all the taxes while the wages are not looked into. And that's why we come out and say, no, we must unite. And in our unity, we must get justice. That when government increase taxes, then the wages also must be increased so that we are able to actually offer the services that gives these particular taxes. When in private hospitals, when the employers there have increased benefits, they've made $1 million or 100 millions of shillings, then it is very important that the wages of these people who actually generating those profits are also considered. Yes. So politics is a matter of interest, and therefore we have to come outside there and advocate that our interest to ensure, our primary interest to show that the patient who comes to the hospital goes home. So our interest to show that patients go home is well facilitated by being paid the right way and by being supported by the right equipment in the right place of work.
I understand that, but there's also a confliction of sorts, right? You have found yourself on the wrong end of protests. You found yourself under threat by unknown individuals based on what has happened when the doctors were striking. How do you handle that? Because like you say, you're not a politician, but you have found yourself in the throes of a very politically heated environment.
For you to be elected as a union official and to represent the people, there's one thing that's fundamental, which is called sacrifice. You must be ready to sacrifice it all, and must be ready to have courage. And courage means that you leaving should be secondary to the work you do. It means that as leaders in the union, you must be ready to die for this particular belief. Because I have seen this and I have a one-hand experience on it. When the government wanted to reduce the wages of interns, one thing was to see how to incapacitate the union. And for that, they will come with fear. When you're going for protests, they'll bring the police and try to stop us. Like they warn us, you cannot protest.
Of course, so there's doctors who have reported being physically threatened during protest times.
Yeah. Personally, last year, I think I was even shot during this protest. But when they realized that the protests and the shootings and the action does not stop, then they say, no, these threats don't work. Then they go to that aspect of firing all of you. You need to be fired from work. But they realize that that's what doesn't work. They now go to the point of bargaining. Then that also, they realize in this bargaining, they must do what is right. That's when we get things done. So that's why I keep on saying that when we take these positions of leadership, the conviction of the right thing being done overweighs us, our personal benefits of living and of enjoying. It is that the conviction that the workers, the doctors' issues must be implemented. So the threats, the victimizations, all these other actions do not work. And that's why we end up having a progressive outcome for our bargains. And that's why I believe also in the Constitution, the drafters of the Constitution realized that to change the status quo of events, there's need a provision for people to unite, protest, and make the public institutions to be responsible and accountable. And it borders the politics, but that's what really drives us. And the unity. Doctors get so united. We may have doctors who don't agree with us sometimes and act like they are not in the same direction. But when it comes to the interest of the union, the interest of our membership, I will tell you that doctors unite in the entire country to take a united action. We will fight as one. And once we finish the war and gain what we need, then we can continue being enemies. So that's one of the fundamentals of our union. That when an issue is affecting interns, when an issue is affecting doctors like the one of Kiambu, which is just happening, when the issue is affecting the consultants, when an issue is affecting any one of us, we must stand all together so that we can actually protect. Because if we don't, then the next victim becomes the next level of the next category.
You're really talking about then the need to restore trust between the public, between doctors, between government, getting all these people to believe in what SHA stands for. How would you encourage that trust to be built?
I believe the current minister on Adendwale has done much more than his predecessors have done in the short time he has been in the office. I think he came in April, and now we are in the month of November. And you've not seen us issuing strike notices or doing protests. It's not because we can't do that. It's because there has been conversations and bargaining and discussions. It's because whatever we have sat down to agree with has been implemented. It's because the proposal that we put forth are actually being considered. As I told you, even in the Social Health Authority, we have been advocating for increased packages, and we are seeing changes in that. It means that it's a progress. We have issues of doctor interns. Last year, we're going on strike for them to be posted, and we paid the right wages. Every year before that, we were going on strikes and on demonstrations. But this year, 2025, in July, we did not have to go on demonstrations or on strike for 6,000 interns to be posted in the right wages. It means that all the actions that you've seen before is because of the provocation. This time we have the issue of the doctors' arrears that were not paid in 7 years that we went on strike for, being paid in September without us going on the street. And now again, the balance that we are having, they've called for a meeting to discuss them. So the proactive nature of leadership in any of these health departments dictates the conversation with the unions. But then you see that there's a difference in the counties. We have a strike currently ongoing in Marsabit. We just have a strike notice coming up in Embu. We are planning to have action in Mombasa. We just finished a strike for 150 days in Kiambu. So it means, yes, that as much as the national government through the minister is doing what ought to be done to have good industrial relationship with the unions, the counties are not doing the same. And that disjointed action is what is causing those particular action. Yes, the magnitude of action is different because now it is patches in different counties. While from ministry it will be nationally seen. That's the only difference. So yes, it plays a key role in healthcare, even universal healthcare, even the WHO pillars of healthcare, that we must have good governance, we must have good leadership to realize universal healthcare.
And you're seeing that. I can see that you have hope and belief in the actions that the current regime is taking in strengthening healthcare.
I mean, they gambled, but the changes that they've made in the Ministry of Health are having seeable or visible results. When we see the new minister, CS Health, and when we see the PS Medical Services, Dr. Omoluga, who was my predecessor in the union, when you see the PS Mudoni, and when we see the appointments that are putting up in the Social Health Authority, the changes of the CEO, the changes of the claim management, the employment, in fact, it's the first time we're having Social Health Authority having many of the technical persons, the doctors in the authority, so that at the end of the day, we don't have the problem we used to have whereby the package is very limited. We want those packages to be looked into. And the doctors who are there, I believe they've been practicing and they know what it means to have an efficient package for patients to access care. So those are the improvements that we have seen. But then this requires an open mind for discussions with the stakeholders. There's need to engage the unions, there's need to engage the civil societies, there's need to engage different bodies, even the patient bodies, so that at the end of the day, the decision that is arrived at is not unilateral to those who are only benefiting. It encompasses everybody that need to access this care.
There's a young man, 15, 16, watching this interview of you and thinking, I want to be a doctor just like Mr. or Dr. Davji. How would you encourage them? What would you tell them?
The reality is, for a long time, and I think even now, many of the top performing students in high school dream of becoming doctors. And the reality is that it's a good profession because while many other professions have other ways of things, being a doctor in Isetat is a vocation. It's a call to serve. It's a call to see to, because every doctor in every hospital, their role in those hospitals is to see to it that this person who has come with so much pain, that is suffering, leaves the hospital walking and happy, is the joy of every doctor. So yes, I would encourage anybody who feels and who believes that they have a call to help the humanity. Some people call it a doctor as second God. But in all this, I must also tell them, when you come, for you to be called to offer these services, you must be well compensated. You must be well protected. And that's why, yes, it is important for people to train to be doctors, but it is also more important for government to see the need to actually employ doctors to offer services in the hospitals. It is the first time in the history of this country that we have doctors graduating and not getting employed, while we have a bigger shortage like never before in the hospitals. This then now make the countries in the developed countries, the Western countries, then have to employ most of the doctors and most of the nurses. It brings about the bigger brain drain. So when that happens in its entirety, it means we are going to have a country that needs more doctors who have been trained with taxpayers' money going out of the country. So yes, I want more young, intelligent and bright boys and girls to graduate and in high schools and join the medical professions and join the union, so that together we can actually build the country. In reality, whatever any young person believes they want to achieve, they can achieve. And they want it to be achieved together with us in a country that we actually can define its future.
I like that you highlight that the exportation of medical labor, which has been ongoing for quite some time, you seem to not be keen on such provisions.
There are two levels of it. I mean, when you have the G2G, the government-to-government agreement that is there between Kenya and UK regarding nurses, it has its benefits, but also it has its demerits. The reality is that as a person who has graduated as a healthcare worker, you don't need to be unemployed, because you have skills that when you are unemployed, you lose. And therefore, getting a greener pasture that will offer you employment or practicing the skills you have anywhere in the world is a welcome idea for you, because you are able to use your skills, you're able to earn, and you're able to live. But it is not good for the country that is highly understaffed, like the African countries, like Kenya now. Because when we have the doctor-to-patient ratio of 1 to 17,000, and we are producing 1,000 doctors every year, it means that it will take us 50 years when we employ every graduate to reach just the WHO recommendation. When you look at the countries like Australia, where they have a ratio of 4 to 1,000, or the countries like UK almost having the same, it's a different matrix with us. Because for us, it's very difficult to see that particular doctor. It's very difficult to get that service. So yes, for the country where there's a shortage, we need to have many doctors who have been educated by taxpayers' money, employed in the hospitals. And that's one of our agreements we had last year. Yes. That we'll be having 2,000 employment of doctors every year. We're actually trying to push that with government, because it has to be done. Because when you don't have doctors in the hospitals, we can't even have the universal health care. We can't even have the social authority working. We can't have anything happening. And that's where we are headed to with counties, because they're not employing. So
the union is then pushing towards greater employment of doctors within Kenya, especially recruiting new staff.
And it should not be only the union. It should be the media industry. It should be the unions. It should be the civil society. It should be the government. Because there's no conversation you can have about universal healthcare or healthcare service when you don't have the healthcare workers. And we have seen most of the counties doing the brick and mortar activities, which people can see, but they can't get service. You'll see a level 5 hospital, level 6, that are being now downgraded by this government or by the current ministry and the KMPDC, because they have just been a shell of institutions. You've been called level 6 or level 5 or level 4, but there's nothing operationalized in that facility that deserves that level. So downgrading it brings the reality that actually they've been hoodwinking the public of their facilities. And that's the reality, because governance does this politically. So there's need to employ health workers in these hospitals so that there can actually be health services in the facilities, and also all other healthcare workers. And this also can happen if there's budgeting for annual recruitment. That's what we're talking about, just like for the teachers and for the military.
Dr. Davji Atella, I am so grateful for your time with us on this episode of Straight Talk and highlighting to us not to be hopeless in the implementation of SHA, that it is going in the correct direction with more implementation, more investment in the infrastructure and hiring within the medical field. And we hope to see that come to fruition in 2026. Thank you so much.
Thank you so much, Yvonne.
Thank you. Thank you so much for watching Straight Talk. I'm your host, Yvonne Checkett. Join us again.